Hi, good morning. My name is Amira Wada. I'm from Instituto Vidas Raras here in Brazil. It's a pleasure to be here moderating this table. We're going to speak about the important issues in treatment in the MPS and related disease. And we're going to start with Professor Joseph Mauser. He's going to speak about the expectations versus the limitations of treatment for MPS. Dr. Mauser is a professor in the pediatric genetics in University of North California in the US. And we thank him very much. And if you guys have questions, send for us on the app so we can ask him after his presentation. Thank you.
Thank you. It's certainly my pleasure to be able to present this talk on the expectations and limitations of treatment for MPS. I want to say hello to my, good afternoon to my European colleagues, and hello to or good morning to my North American and South American colleagues, and actually good evening to my Asian colleagues. It's unfortunate we can't be in person because of COVID. I think one of the things that I enjoy most about this meeting is actually the interaction and meeting colleagues from around the world and seeing patients from around the world. What I'm going to do in this presentation is really sort of give you initially a little bit of overview of MPS, which most of you know, but I want to use that as just as a way to contrast some of the expectations and limitations. And then I'll same thing to do for treatment, and I'll sort of talk about the current treatment, but also just contrast what works and what doesn't work. I have a lot of conflicts of interest because I do consult and serve on advisory boards for a variety of pharmaceutical companies. I'm a principal investigator for a variety of clinical trials, particularly a phase 1/2 and a phase 2/3 intrathecal enzyme replacement trial for MPS II, a gene editing trial for Hunter syndrome for adults, a phase 1/2 IVER trial for Sanfilippo-A, and a phase 1/2 IVER trial for MPS II, both of the latter two designed to try to treat the brain disease. As we all appreciate, the MPSs are a group of lysosomal storage diseases, but what makes them more challenging is that there's actually 11 known enzyme deficiencies in 7 different clinical types. As an aggregate, if you take all of them, they're still rare, but they're not that rare, of 1 in 25,000. Each individual disorder is actually very rare, and something like MPS 7, maybe 1 in 500,000. So that rarity makes really a challenge. The hallmark of these disorders are the tissue storage of glycosimic glycan, but patients, I'll show you, store different materials. This really can affect multiple different organs, and as we all appreciate, take care of these patients, we can see cognitive impairment and reduced life expectancy in some, but not all. Because of this ongoing storage, these are progressive diseases with basically multisystemic involvements, and these lysosomal enzymes or housekeeping genes are needed in every cell for normal function. But what makes it really challenging, in terms of care and diagnosis, is a wide range of clinical involvement in onset and severity for each of the MPS disorders. And this slide just shows you sort of pictures of patients with MPS, as you all appreciate. An adult with MPS II, Sanfilippo, for example, an MPS 1, an MPS 2, an MPS 1, an MPS 2, MPS 3A, and MPS 1. Individual with Hurler syndrome, another Sanfilippo. So this just shows you the variety and variable onset of these patients, from children to adults. Well, I'm having a problem advancing. Thank you. Maybe it's just a time delay. The other challenge is really there's a spectrum of disease in the MPS population. There's very different. For example, non-immune hydrops, where you see sort of edema or swelling in infants. It's really the common presentation of MPS 7 or SLY syndrome, where we rarely see that in any other forms of MPS. Where in contrast, MPS 1, 2, 7 all have physical and CNS involvement, central nervous system involvement, but never only have brain involvement. They always, if you're going to have brain involvement, you have the physical involvement. In contrast, Sanfilippo patients, it's a primary brain or neurologic disorder, and historically the mild forms were not detected because we just missed them. And now in the era of next generation sequencing, we're picking up some of these milder but still significantly impaired patients since they didn't have any obvious physical features for people to think about an MPS disorder. MPS 4A is really a skeleton disorder when these individuals have normal intelligence, where MPS 6 Merritt-Tolomei syndrome is primarily a physical disorder, again with normal intelligence. So you see this wide variability, and this actually can, expectations have to vary because depending on the disorder you have, you can have very different outcomes even without any intervention. The other is, in terms, I want to talk about the disease pathophysiology, because one of the expectations from my view is that we talk about residual enzyme activity. And if you have no residual enzyme activity, that is, you actually can't make any enzyme, you have the severest form of the disease. But for example, in MPS 1, if you make a half of 1% of iuronidase, you actually have Shea syndrome, a disorder which is very attenuated, where you do not have the neurological involvement we see in Hurler. So tiny differences can make a huge difference in clinical outcome. And so it's important to realize that the routine diagnostic assay cannot predict this residual enzyme activity. This is really more for research purposes, and you cannot use the enzyme activity that you see on your diagnostic test as a predictor of severity. The other important issue is the major classes of accumulating glycosamine glycans are not equally distributed throughout the body. And so, for example, in Sanfilippo syndrome, we primarily see only heparin storage because that's what those enzymes work on, and that results in the central nervous system, where dermatan sulfate is found in the somatic or outside the central nervous system. And in contrast, keratan sulfate is really primarily found in the bone. Excuse me. Morquio A is primarily a bone disease, even though we can see other involvement too, but this just makes the expectation and limitations more challenging. This unique glycosamine glycan storage for each MPS disorder, as we already appreciate, results in a wide range of clinical disease. But more importantly, though, in addition to that, there's a variety of secondary events that result in a complex cascade of clinical disruption once you have storage of GAGs. And this slide just sort of gives that a little bit. Here it just shows you the gene mutation results in a deficient enzyme, and this is GAG storage. And this occurs in all the MPS, but depending on what accumulates, you may have different aspects. You may have more extracellular GAGs resulting in inflammation. You can have a lot of other secondary events in terms of dysfunction of the lysosome. You can have oxidative stress, abnormal mitochondria, abnormal calcium signaling. And the challenge is that once these processes get going, they may not be reversible, even though you can now put a missing enzyme into the lysosome and stop the storage. These other secondary processes very likely could be irreversible or very difficult to bring back in control. So let's talk about now treatment. Enzymatic correction is possible at the cellular level in the MPS fibroblasts. Secondary to the following observations, we've been aware of this for 30 or 40 years. We've known that cultured cells release small amounts of lysosomal enzyme, and my mentor, Liz Neufeld, years ago, termed this correction factor before she realized this was really the cause. These were really the lysosomal enzymes coming out. More importantly, people recognize there's a very efficient means to actually take up enzyme into cells if it's on the outside through a mannose-6-phosphate receptor-mediated uptake. But probably the most important concept is that we only need correction to get correction of GAG metabolism, we only need maybe 1 to 2% of residual enzyme in that cell. But the key is in that cell, and you have to get enzyme into that cell. And so one of the limitations is that for a lot of the treatments, we don't get enzyme into every cell. And this concept of correcting cells from one cell to the other is called cross-correction. And you'll see that in the next slide where you have this schematic. I'll have to show a little bit of cell biology. If you have a cell, we make enzyme in the rough end deposit from reticulum. It gets a mannose-6-phosphate put on. If you can't do that, that's I cell or mucolipidosis 2 and 3. And then normally once you have that mannose-6-phosphate, it goes to the Golgi and then gets delivered to the lysosome. This process is not 100% perfect, and some of this enzyme can leak out. It can either be taken up by that same cell, or, for example, if this is a transplanted cell that's been corrected, the cells around it now can be, receive a little bit of enzyme and be corrected. So this concept of cross-correction is really unique for the MPSs and allow us to probably do as well as we're doing, because it's very difficult or impossible to treat every cell in the body. The 2 current treatments that are approved are listed here: hematopoietic stem cell transplantation. And I use IV enzyme replacement therapy since we're also involved in clinical trials with intrathecal. So it's important to distinguish, intravenous versus intrathecal, where we put the enzyme directly in the spinal fluid, which I really won't talk about today. In terms of hematopoietic stem cell transplant, the first one occurred in a Hurler child in 1981 in the UK. Today, instead of cord blood as the donor, we're using umbilical cord. And so now most patients will have donors available where that's being done. As a lot of you appreciate, hematopoietic stem cell transplantation is the current treatment of choice for severe MPS I or Hurler patients if they're less than 2 years of age. One of the limitations is if clearly historically where we transplanted older patients, they did not get the same neurologic correction. They got the same somatic correction, but if you transplant a child who's had already significant neurologic disease, they tend not to have the same stabilization, where if you transplant them under 2 years of age, it's much more likely to see neurological stabilization. It's also important to realize this is not a benign procedure. Even in the best of centers, mortality is probably 5 or 10%. It's getting better compared to what it used to be. That mortality is typically within the first year of life, even though there's occasionally late deaths for unexplained reasons sometimes. But it's not a benign procedure, and if you consider transplantation, you really have to accept the fact that your child could die in the first year after transplantation. So that's one of the major limitations of stem cell. Hopefully in the future this can get lower and lower. If this was 1 or 2%, then it could be a much more universal treatment. But right now, it clearly has to be thought of it in terms of that mortality, and I'll talk about more of the different patients. One of the other crucial issues is the timing. To treat the brain disease or the central nervous system disease, it takes time. What happens is we believe that donor-derived macrophages or white cells go into the brain. They now become resident microglia cells, and now in the brain, these resident microglia cells will release small amounts of the missing enzyme, and these missing enzymes then can cross-correct cells around it. But it doesn't happen. So in a very rapid progressing disease, this doesn't work anywhere near as well. Why it doesn't work also later, once you have significant disease, we don't see correction. Most likely the damage is too severe and irreversible. Certainly newborn screening is important, and because of showing that it's been shown that transplantation done in younger patients, as you heard yesterday in terms of this meeting, if you do it less than 9 months of age, you get a much better outcome. And so now MPS I has actually been added to the recommended newborn screening panel in the US, and more than half the US states are now screening for MPS I. And the hope is that we'll add other MPS in the future, and I'll talk about that a little later in this presentation. So what are the expectations? Certainly if you get successful and stable engraftment, and that's an important consideration. As what happens is with transplantation, you use chemotherapy typically to wipe out the bone marrow, do a donor infusion, and it takes time for this donor infusion, the cells to set up a house basically in the bone marrow to make more cells, and so that takes time. And so that if you have that, then you do get long-term clinical improvement. But it's important to realize one of the limitations of transplantation is that we're not really treating the bone disease, and we're not treating the corneal clouding. We do clearly increase long-term survival in the Hurler patients if they're transplanted, but they clearly can have significant orthopedic issues, and most successfully engrafted MPS I patients need multiple orthopedic procedures because we're not treating that. Transplantation has been used for a treatment for MPS VI. It typically is not done now because of enzyme replacement therapy. It's also been used for MPS II and IIIA and B. However, the results of the central nervous system for MPS II and IIIA and B have not been successful as severe MPS I, and it's not clear why, whether it's the timing, whether it's not done early enough, or whether there's something unique about those diseases where you don't get enough enzyme being produced in the brain, or they need more enzyme. But again, you have to do it early. If you don't do it early before neurological disease occurs, then you really get a very poor outcome. So just that summarizes sort of that view that transplantation is really beneficial for MPS I and II. It's unclear how well it works for the brain disease, and clearly for some individuals it's been beneficial, but it's still not the same as MPS I. It has not been successful for the bone disease in Morchio. Clearly could work as a treatment for MPS VI, but it has a much higher risk than IV enzyme replacement therapy. So what about intravenous or IV ERT for MPS? It's been approved for, as we all know, for MPS I, II, IVA, 6, and 7. It has improved, so the expectation is it should improve quality of life, and it does increase survival, and as we're seeing more data, we're going to see that. But it's really important to realize this is not a cure. It doesn't take away all the problems. It's really only a treatment. It's important to keep that in context. So that's one of the limitations. Yes, it does dramatically change the outcome for her or child, but it's not, or for an MPS II child, but it's not a cure. We should expect, though, that ERT for MPS will result in reduction of urine GAG excretion and decreased liver and spleen size. That should be an expectation that we all see in these patients. And if you don't see that, then you have to wonder what's going on with ERT in that individual. Well, what's the other expectations for IV ERT for MPS? We should see some improvement in joint range of motion, maybe pulmonary function. This energy and endurance can occur in patients in the first 6 to 12 months of treatment, but we don't see long-term continued improvement. You see benefit early on, and then it's sort of, then it's really stabilized. And this lack of long-term clinical progression should be really considered success, because then it's very difficult to reverse clinical disease, and it's usually not possible. So it's important to realize that, and this is one of the challenges for reimbursement, that after the first year, we don't see these kids any better, but just preventing progression is benefit, and that's hard for some people to understand, especially regulators where they want to see continued improvement or want normalization, which you won't get if you already have significant disease. One of the things that's always fascinated me about IV ERT is that we see this improved endurance, activity, or energy for a number of individuals after IV ERT. We didn't expect that. Its mechanism is unknown, and it's just an interesting phenomenon, but there's certainly some individuals really dramatically see this impact and how they feel for reasons that we just don't know. So again, this just summarizes that there's certainly IV ERT available, but the question is why not for Sanfilippo's? Well, as we all appreciate in this field, is that these large enzymes, we can give IV and they can clearly make them these days, but they don't typically cross the blood-brain barrier. And so IV ERT is not expected to help the primary brain disease. And so as most of you with Sanfilippo syndrome realize, yes, there's some physical disease, but they're really the major issue is the progressive neurologic disease. And the same way for IV enzyme does not help the neurological disease for MPS I or II. So let's just talk about some of the limitations of the current treatment. Most MPS patients at the time of diagnosis already have significant disease burden. Clearly, if you have a sibling, then it's a different story, but for most patients diagnosed based on clinical criteria, that's already significant. And that disease burden, by and large, I think is irreversible. Historically, we thought we could reverse it, but I think one should assume that most of that disease is really irreversible. The other important thing is that IV enzyme relies on giving circulating enzyme into the body after a sort of a short-term infusion, or I call bolus infusion. This enzyme doesn't last very long. It gets taken up. But it's important that to correct the cell, we have to expose that cell to enzyme. And there's certainly some cells that we can't get into, and I'll talk more about that in a second. And so one of the limitations is that yes, we get increased enzyme in the circulating, but it can be very quickly taken up by the liver where we don't really need anywhere near as much. As we all appreciate, typically requires weekly infusions, even though the MPS 7 product is actually every 2 weeks, the last one being approved. It's incredibly expensive. And as we already alluded to, did not treat the brain disease. And since the IV native enzyme does not cross the blood-brain barrier. Clinical trials are in process to try to modify the enzyme in the different MPSs to actually cross the blood-brain barrier. And that work is in progress, and hopefully we'll see benefit in the future. The other important limitation is that there's some tissues that we really are not impacted by either IV ERT or transplantation. And these tissues tend to be relatively avascular, and so they're not directly supplied by blood where you can directly expose the enzyme to the cell of interest. And so that's a major limitation. So the synovium, the lining of the joints, one of those, the trachea and MPS 2 particular, the tracheopathy is something that's very difficult. And we're seeing major issues in some of the adults with MPS 2 with this problem. As I already alluded to, the bones are really not impacted so that very successfully with treatment. Same way with the corneal clouding, and carpal tunnel syndrome clearly is another example where we tend to see recurrence of symptoms even after treatment on patients on IV enzyme replacement therapy. As we already alluded to, there's really no effective treatment options for most MPS patients who have central nervous system disease, except for MPS 1, and hopefully in the future we'll hear about treatments for those. The current approved dose for IV ERT is clearly beneficial, but most likely not the optimal dose. In the early days of getting MPS 1 and MPS 2 approved, it was very challenging to make the recombinant enzyme, and so there was really not a lot. So the doses we used in those trials were sometimes limited by what could be made. And so it's important to realize that as we've gone along, the more recent approved IV ERT products are actually higher doses, sometimes 3 or 4 times the initial doses we use for MPS 1 or 2. One of the other things is that weekly infusions are time consuming. It takes 3 or 4 hours, and it can really result in a whole day for some people. But shortening those ERT infusions, even though it's convenient, may result in more enzyme being delivered to the liver instead of to cells where you really want it, because the enzyme doesn't last very long. And so I strongly recommend people to follow the guideline in terms of not trying to shorten the infusion. And even for MPS 2, it talks about a 1 to 3 hour infusion. I strongly recommend people to stick with the 3-hour infusion, even though I don't have a lot of data supporting that's better. The other important thing to realize is that MPS enzymes have to be taken up by the cell of interest to work, and they have to get to the lysosome, and that the circulating enzyme does nothing. It has no benefit whatsoever except as allow the enzyme to be distributed. And so the more circulating enzyme you can have, the longer it is, the better it would be for your individual disorder. What do we need to improve outcomes? Certainly identifying patients much earlier by newborn screening and starting treatment before the onset of disease, to me, is really the paramount. You heard in the initial lecture in this symposium about newborn screening, where in the Netherlands they're now doing MPS 1 newborn screening. But I would argue that, even though that presenter really didn't talk about or discourage the idea of doing MPS 2 or Sanfilippo newborn screening, I think it's so valuable. For example, in MPS 2, yes, we can't treat the brain disease with IV enzyme replacement therapy, but starting patients physically on enzyme at 6 weeks of age or 3 months of age versus 2 or 3 years of age, we see a dramatic clinical improvement. And that, to me, enough should be. Yes, these treatments are not perfect, but even in Sanfilippo, identifying patients Even though some of them may have very late onset disease, the vast majority have earlier onset, and you can dramatically shorten that diagnostic odyssey. The other area that probably in the future will have an impact is that small molecules can be used to impact tissues not improved by circulating enzyme, where small molecules can diffuse into spaces where large enzyme cannot. And I'll come back to that in a little bit. Better understanding the impact of antibodies against the administered enzyme and obtaining super physiological levels of circulating enzyme may be a way to overcome some of this, where we have constant levels of enzyme bathing hard to reach tissue, then that may be a circulation. You'll hear a lot more of gene therapy at this meeting. The limited data available suggests that actually GAG storage starts in utero. As I also strongly feel, it's most likely much easier to prevent onset of clinical disease than to stop or significantly slow the progression. We need really to sort of prevent disease from occurring. And therefore, we need to identify patients by newborn screening. And this really should be one of the major pushes in the future to do this, really. And I think we'll see a dramatic outcome in improvement. Yes, it's not without problems. It's not fraught without issues, but it clearly needs to be the only way we're going to dramatically change the course for a lot of individuals. Small molecules clearly could be used. There's a clinical trial in Europe now that's reducing glycosaminoglycan accumulation, so-called substrate reduction therapy. People have proposed in the past to increase residual activity in patients who have nonsense mutations or stop codon read-through therapy. There's clearly medications being looked at to improve autophagy, to try to improve clearance of lysosomal storage. And we know that for some individuals, reducing inflammation may have some clinical benefit, not treating the primary problem, but treating a secondary. One of the areas I won't talk about much, but clearly is probably a significant issue, the impact of antibodies. And in patients who make no residual enzyme whatsoever, so-called null patients, those patients do make antibody because giving the native enzyme back is like a foreign molecule, and that really has impact. It doesn't totally prevent efficacy of enzyme replacement therapy, but clearly impacts it. And again, the idea of that maybe the future is that getting super physiological levels of circulating enzyme, and a lot of our issues will be taken away, but it's still it's not without time before we see that. So in summary, there's many aspects of clinical disease and MPS that are probably irreversible. Proving outcome most likely will be obtained if treatment is started before onset of clinical disease, and that by and large really is newborn screening. These disorders are rare enough and that are difficult to recognize early on, that only newborn screening is going to allow us to pick them up in a very timely manner prior to onset of significant disease. Prevention, but not correction of clinical disease should be the expectation. We're not going to cure these individuals. Routine clinical assessments need to still continue, since ERT does not solve all the problems, and you can identify problems and sometimes have surgical or other correction before they get too severe to improve outcome. But more importantly, as we've seen over the years, new treatment approaches are needed to improve outcome for the central nervous system disease, for the bones and joints, for the trachea, for the corneal clouding, and for patients with high antibodies. And these are areas that you'll see talks at this meeting in some of those areas. I thank you for your attention. I'm happy to now take questions.
Thank you, Professor. Your presentation was great. We have two questions for you. One was about the transplantation for MPS 7. There is an interrogation on if there is an option or no. And do we have any information, or the data are not sufficient enough to know if it's helpful or not?
I would guess, since MPS 7 looks a lot like MPS 1 in terms of its disease, that if treated early enough, that transplantation would be an option for MPS 7, even though I think the experience is probably very limited. I don't know that literature as well as I should.
Okay. The other question is, a higher level of heparan sulfate means a more severe affection of the patient's CNS. Whereas a higher, sorry.
Go ahead, keep sorry.
Whereas a higher level of dermatomes sulfate would result in a more severe somatic affection.
So again, it's not clear if we can correlate the level of stored gag with clinical severity. There may be some association, but you cannot make that directly. Yes, elevated heparin sulfate typically means you have could have neurological if it's in the spinal fluid, but the correlation from severity, I don't think we can make that prediction yet.
But this can determine somehow the clinical outcome.
Oh, absolutely, because again, if you're storing dermatan sulfate, that means you're getting not correcting the storage in the physical or somatic part of the body. In the same way with if you have heparin in the brain and spinal fluid, you're not correcting the brain disease because you have ongoing damage and you have ongoing release of the stored material.
Okay. We have two more questions. What is the optimum dose for ERT and MPS II? And how would you say is the best infusion time rate?
So the recommended dose is 0.5 milligram per kilo. We don't know what the optimal dose is, unfortunately. And I recommend the 3-hour infusion time.
Okay. And the last one is, does the transplantation helps in cardiac progression?
Yes, if you get it before you have significant cardiac disease. Transplantation is a form of enzyme replacement therapy. So successful engraftment basically results in a lot of circulating enzyme. And so for anybody with a MPS who has physical involvement, it should help or stabilize. Once you have significant cardiac disease, abnormal valves, IV enzyme or transplantation does not work.
So we have the last question. If you had the power, would you approve the newborn screen even for disease where there is currently no treatment as Sanfilippo?
I would, only because it allows us to identify these patients much earlier. We can avoid the diagnostic odyssey. We can allow them preconception planning, and it'll allow for there's so many now clinical trials ongoing for Sanfilippo, that the key is really picking them up early, because if we treat a Sanfilippo at 4 or 5 years of age with any interventional therapy, we won't see a very good outcome because it's already severe brain disease. So from my mind, that only if we treat them early, and the only way we're going to treat most Sanfilippo patients early is to do newborn screening. Yes, there's not without problems. There's, as we heard it yesterday, there's some attenuated patients who prevent much later, but I'm not sure if that small subset should ignore the vast majority of patients who have severe disease by the time they're 3 or 4 or 5. A challenging issue.
Yes. I think we have time for one more question. There is a question about the gene therapy. Do you think that with these new treatments, this is the viable route for thinking about the CNS impacts?
So gene therapy is one potential route. It may be that, modifying the enzyme and giving them IV that cross the blood-brain barrier, that's another. We'll hear about that at this meeting too. But gene therapy, if you can get enough expression in the brain, yes, it could impact. But again, gene therapy itself is not perfect. And there's patients, since we're using AAV vector, patients have pre-existing antibodies, and so not everybody is eligible. So there's still lots of challenges, but gene therapy has the promise, it's not guaranteed yet, to dramatically change the brain disease if we can get enough expression.
Okay. The last one, because this is a really good one. Is there any results on the benefit of doing ERT after the transplantation?
For most individuals, I would say no, who are successfully engrafted, but that's, there may be some patients who could benefit from ERT, but that's still a controversial issue. That's a whole nother talk.
Yes. Thank you, Professor, for your time, your presentation. It was very helpful. And we're gonna go to the next one. We're gonna talk now about the behavior and sleep problem in patients with MPS. And we're gonna have Dr. Mar O'Gallagher. Did I say your name correctly? She's a pediatric neurologist in the Department of Neurometabolism in the hospital in San Juan de in Barcelona. And she'll be doing this presentation with Dr. Mireia Del Toro. She's also a pediatric neurologist in the hospital in Val de Hebron in Barcelona. Sorry, I didn't say this name correctly. Thank you, doctors, and it's on you.
Okay. Okay, thank you. Thank you to the organization for inviting us to talk here. As Amira said, we are both neuropediatricians in different hospitals in Barcelona. We both take care of the lysosomal units in our hospitals, and we are involved in the patient care and in research and clinical trials also. And we are happy to be here and hopefully trying to help the families to deal with behavioral and sleep disorders. We know that from an organic point of view, maybe they have not such an importance in the medical care, but they are, well, they can have a big impact in the daily life of patients and of families especially, and they have a great impact in their quality of life. So we will try to go through it and to see if we can help. These are our disclosures. We also have, we also are involved in clinical trials. And I will begin asking Mar if she can, well, give us an overview of behavioral problems in MPS patients.
Thanks, Mireia and Amira, for your kind presentation. I'm happy to be here with the families. And before starting with behavior and sleep disorders, I want to introduce that neurological involvement in MPS is due to the secondary GAG accumulations in brain, heparan sulfate, and secondary accumulation in other tissues as meninges, spine, and ligaments. The neurological manifestation in MPS are common in the different MPS and can leave a great impact in the quality of life of patients and families. And the clinical manifestations can differ from one to another MPS. As Dr. Mwenzer said before, and as you know, the enzyme replacement therapy don't cross the blood-brain barrier and is not effective in preventing the neurodegeneration and the neurological manifestations. Regarding the primary central nervous system involvement, the patients present psychomotor delay, neurological deterioration, behavior and sleep disorders are important in MPS with neurological involvement and the hydrocephalus. And let's move to behavior and sleep disorders, Mireia. Regarding behavioral problems, in MPS are frequent and usually start at the age of 3 or 4. It consists with hyperactivity, change of mood, abrupt change of mood, aggressive behavior, tantrums, frustrations, and the patients has all these problems, and they are quite to the family, As you can see in this paper, behavioral problems are present in the severe forms or in MPS 1 or in MPS 2 with the neurological forms of Hunter or Hartley disease, and always are present in Sanfilippo disease in all the subtypes. And it consists with hyperactivity, mood change, aggressive behavior, as I said before. Go on. Okay. Important to remark that the behavioral problems usually precede the cognitive decline. It's the beginning of the neurodegeneration and usually precede the cognitive decline. And with the progression of the cognitive decline, the behavioral problems are less prominent. And for the clinicians, it's important to rule out possible triggers to the behavioral problems. First of all, we have to take into account the sleeping problems, because they are related in PS, and we have to rule out sleep problems like sleep apnea, respiratory problems during the sleeping, the EEG activity, epileptic activity during the sleep, the pain in these patients who don't have ability to explain what they happen, and the hearing deficiency. And we have to try to take into account the environmental trigger and the reactive anxiety. And I want to take a mention to the hydrocephalus, because in the clinical practice, Mireia and I think it's important to know that is underestimate, because sometimes it's a chronic and slowly procedure, and there is no an acute clinic. And the clinicals have to consider the possibility of hydrocephalus when the patients present a rapid deterioration in cognitive or in behavior. And now, Mireia, how, from your experience, how do you manage, or how do you could help the families with the behavioral problems?
Well, thank you, Mar, for your introduction. Then, well, the first thing is to evaluate. No, we've seen that behavior can be a problem in several MPSs, and it can also be triggered by different situations. So the first thing is to do a good clinical history, evaluating when the behavioral problems are present, a clinical evaluation to rule out all the different issues that Mar has already commented on. We will perform neuroimaging only if we really suspect that hydrocephalus, another neurological condition, has to be ruled out, because neuroimaging these patients requires a sedation. Sedations are complicated. They have to be with an expert anesthetist, etc. And the same is for EEGs and evoked responses. Regarding psychological testing of behavior, there are different scales that you can see here that are validated for different MPSs, normally in the context of clinical trials, but they are also valuable in clinical practice. But they have always to be done together with a neurocognitive scale, such as Bailey, Kaufman, or whatever. Behavioral testing has always have to go side by side with the neurocognitive evaluation. Mm-hmm. And then, because we've seen all the problems that these patients can have, and behavior is not a unique problem, it's always related with many other issues in the clinical picture of patients. The management of behavioral problem has to be multidisciplinary. Of course, psychologists, psychiatrists, and neurologists will have a predominant place, but all the other different specialists have to be involved in the care, and of course, especially family and school and the other environments where the children is in his daily life going to. We have to rule out and treat the possible triggers. We will not go through again because we've already commented on. We will try, before going to pharmacological treatment, we will try to do environmental interventions, such as put the patient in routines that can reduce the anxiety, keep them in safe and well-known environments that are not aggressive for them, and also have a safe and comfortable environment at home and at school. And if the patient understands enough to understand reinforcement, then we can identify which factors are reinforcing for them and can help them to be more calm. If the patient has hearing loss or communication issues and this frustrates them, we can try to help them with alternative communication programs. And if the patient has an enough cognitive state to understand rewards, then we can try to reward their improvements. And finally, in some cases, not least, but we have to try and we will need pharmacological treatment. Pharmacological treatment is not easy. There's no effective treatment for different kind of patients, and a treatment that works for one patient cannot work for another one with the same condition, and even they can create a paradoxical reaction. So we have many different many different options in pharmacological treatment of behavioral issues, but as I said, what works to one patient doesn't work for another. And another thing that happens as well as with epileptic drugs is that tolerance occurs some months later. So the patient is good on one medication, and then some months later he is beginning to worse again. You have to increase the dose, or you have to change the pharmac, and this is very frustrating for families and also for doctors. So as a summary, behavioral issues are not easy to treat, and they need for a multidisciplinary team approach. And then Mar, I will handle it to you again. Just you can explain us something about sleep disorders.
Thanks, Maria. Sleep disorders is a main problem in MPS and are due to the neurodegeneration, but we have to take in account that in MPS 1, MPS 2, and like MPS 6 and MPS 7, these MPS with a skeletal malformation and skeletal disease, we have to take in account that they have respiratory problems. So the sleep disorders could be produced by all these respiratory problems. During in this MPS, the obstruction of the upper airway could lead an obstructive sleep apnea and hypopnea, South disease. The muscle weakness of the diaphragm and the restrictive pulmonary disease could lead to problems during the sleeping. The patients don't want to go to bed or wake up during the morning, and nocturnal hyperventilation. And it's important to remark that these sleep disorders and this hyperventilation could lead behavioral disorders too. And regarding the sleep disorders, due to the neurodegeneration, are prominent in MPS 3 in San Filippo, in all the subtypes of San Filippo, and are frequent in MPS 1 and MPS 2 forms, in severe forms of MPS 1 and MPS 2, and usually precedes the cognitive decline as the behavioral problems. And it consists with setting difficulties or wake-ups in the morning and crying, tantrums at night, and they are difficult to manage and for the patient and for the families. And regarding the management, Mireia.
Yeah, well, regarding evaluation, the same as we already talked about in behavior, I will not go through. Maybe the only different thing here is that polysomnographies are very useful because they can both rule out epilepsy problems and respiratory problems, and it's something we have to perform this, yes, in regular basis. And regarding the management, first, well, ruling out the problems that Mark commented on respiratory and ENT problems and treat them as aggressive as they need. And some of the children even need nocturnal ventilation just to help them to breathe all night. After this, again, we can try to improve routines. We can use melatonin as an induction as an physiological induction of the cycle of sleep and awakeness. And this is a work that showed that MPS 3 patients had basal levels of melatonin quite lower than the controls of the same age. And if nothing of this works, then we have to go to more important pharmacological medications. Just to, before summarizing, just to understand what's the burden of the disease for families, these are two studies with MPS 2 neurological patients. One showed the impact of the family impact and having a patient with a son with an MPS 2 neurological condition, and nearly 50% of the parents had to organize the working hours or to attend the patient care. 22% of them reported that one or the two patients had to leave to stop working, and it were frequently the mothers that were the most frequently affected in these working changes. But there was also the economic burden from traveling from home to the referral hospitals, to the ERT, or to the visits or whatever. And this is another study also with MPS II neurological patients, families, regarding pediatric quality of life. And what family says was that as neurocognitive involvement and behavioral problems worsened, the social activities of the family, the relationships, and the functioning of the whole family decreases. No, and even inside the family, the siblings were affected by all this problem. And the patient worries, and this is something we are usually hearing often in our clinical practice, is the parents fear about child suffering, but they also fear about what will happen with the child if they are not present there to take care of them. So this is just to show that really all these neurological problems have a very important impact in not only in patient psychological status, but also in families. And now we would like to finish just because we're going quickly through a lot of information, and Mar will summarize the most important points of our presentation.
Thanks, Mireia. Just to take home message, as we explained, behavioral and sleep disorders are common in MPS patients with neurological involvement, and it's an important burden for families, as you know. The pattern involvement differs from one MPS to another and from one patient to another. So for the clinical, it's important to evaluate every patient and to treat every patient. It's important to rule out the triggering factors, environment, and to try to improve environment and routines or pains or other problems who are triggering these behavioral and sleep disorders. The treatment requires a multidisciplinary approach, special attention with the family needs, and pharmacological treatment. Sometimes it's necessary for the severe case. I think it's necessary, but always it's necessary to have a continuous supervision of a medical team. And Mireia and I am here. We are here to, if you have some questions.
You're muted.
Yes, sorry. I do have a question. Why it's so common for patients with neurological disease to have such tolerance for medication? Because we have here patients use for 1 month and they just stop to respond to treatment, and we see that the families get very desperate because they don't know how to deal with their kids. So that's something that it's very frustrating for them and for us as an organization here.
Well, I can begin, but then Mark can give her opinion. No, I think that the problem is that all psychological medication uses biochemical routes inside the neurons, no, inside the pathways and the synapses and all the different. So I think that sooner or later they get saturated, and that's what happens also with anti-epileptic drugs that are also involving the synapses. No, in some moment that route gets saturated. I think, I don't know. I don't have the exact, but I can imagine it's similar to what happens with epileptic drugs. And yeah, it's really desesperating for families, because once you find something that seems to work and they begin to breathe, then it stops working.
Yeah, it's desesperating for the families and for the doctors. But I think it's important to remark that that to rule out or to look for the seizures or epileptic EEG when the behavioral problems start, because sometimes the psychopharmacs are not working and we have to start with an anti-epileptic drug.
You guys talked about the polysomnography, and I don't know if I spoke this in English correctly.
It's okay.
Yes, it's okay. I think it's okay.
And we have to do this once a year, every 6 months. What's the best time to do this follow-up on the evolution of on their sleep?
Mireia?
I can begin. I think, well, depending on, this cannot be generalized. I think it depends on the patient. No, we have to have one polysomnography at the age of 2 to 3. That's when night problems begin. And then we usually keep on with the pneumologist and the ENT specialist if it's only because of breathing problems, and then depending on what actions they are having on the patient, we decide, yeah, once a year should be good, or maybe once every 2 years if the patient is stable.
It depends on the patient, and it depends. Perhaps if the patient has a surgery of otorrhino, we don't have to do every 6 or every year.
Okay. We have another.
It's not easy. Sorry, it's not easy to perform this in a moving child.
Yeah.
To put all the electrodes in to make them sleep in an environment that's not his home. So it's not easy either to do it.
Yes, exactly. Sleep is such an important factor in the quality of life. Are there any research projects or clinical studies into maximizing sleep medication effects for MPS patients?
Sorry, can you repeat?
If there is
any study to
a clinical trial.
Yes.
No, there have been studies with melatonin. These ones that showed that the melatonin levels in San Filippo patients were low, and then there has been trials. But I'm not sure. I don't think there's been a trial but it's a good idea. We could try to not to do a trial, but to recall all our patients in a multi-center study and see how we treat them and see what works better. Yeah, but I don't think there's a trial ongoing with this.
We have one question from a mother of a patient with MPS 3. He's 20 years old and she just started using CPAP, but she can use when not supervised. Is 2 or 3 hours of good sleep beneficial?
So if only 2 or 3 hours?
Yes, 2 or 3 hours. He cannot use it without supervision.
Yeah, that's a problem, that many of these patients begin with CPAP and at the half of the night they just throw it away and they keep on sleeping. Well, I think that's better than nothing. And of course, you cannot be forcing a patient that's severely affected to use the CPAP all the night, no?
How can... sorry.
No, go on.
How can we detect or prevent these convulsions during the sleep?
I think doing a EEG or PC or polysomnography when we suspect or when there is a problem in the sleep or behavior change. And sometimes if the epileptic activity appears in the EEG, sometimes we start treatment with antiepileptic without epileptic seizures. I don't. Yes.
Yeah.
But I think we have to do a EEG at night, polysomnography to try to
understand.
So,
Only one short answer to the mother that took
San Filippo.
I think that maybe using some pharmacological induction of sleep could help to maintain the CPAP more time. But this she has to consult with her doctor if there's any contraindication.
Okay. We have a lot of questions, and I think we have time to do more 3, if it's okay for you. If sleep disorder, does it always mean there will be a neurocognitive impact?
Sorry, could you repeat?
No, you can have sleep disorders in a patient with MPS 6. No, Mark talked about patients without cognitive involvement, but with respiratory. No, Mark, you can.
Yes. But if you have an MPS, a kind of MPS 6, for example, with no neurodegeneration and with no neurological impairment in the brain, if we have a sleep disorders, you can have a behavior disease, but not by the neurodegeneration. Sometimes anxiety or sometimes hyperactivity, ADHD, but mild, not a neurodegeneration. Is due to the not good ventilation during the sleep. Could you understand? Yes.
Yes. How about using TBC? I don't
TBC?
know.
TBC?
Yes.
TBC
Yes.
is TBC.
TBC.
CBD? Cannabis?
No, CBD.
CBD.
No, TBC. What's TBC?
I don't know.
CBD maybe.
Yes.
THC, tetracannabidiol, no? Or
Yeah, I don't know.
Or CBD.
Maybe they mean yeah, no, carbidiol.
Sí.
We have experience in some patients that have used it for behavioral issues and sleep issues, and it has worked. But again, the problem with CBD is that we don't know the dose, and the commercial oils that are that you can buy, we don't know the concentration, and it's also a very quick tolerance that patients have to this approach.
And there is no studies, Mireia, with CBD in patients.
There is some study, but with not conclusions.
Let me see. Can I read the question in Spanish?
Yes, we can translate.
Em síndrome relacionado como la gangliosidose GM1, observamos fecalomos frequentes. Há uma alimentação mais específica para essa enfermidade?
No.
No.
They are asking if digestive problems and fecalomes can
in GM1
they can have, as Mar said, they can be painful, no, Mar, and they can give problems during sleep because they are painful and irritability. No, I think they have to connect with the nutritionist, and they will try to perform the best diet and the best treatment.
But if the patient has fecalome, he can have a behavior disorder and pain and sleep disorder. But you have to treat the fecalome or the constipation, but there is no specific diet, I think, or treatment.
How important is to do an MRI of the brain for MPS to patients to check hydrocephalus? I think for MPS patients in general.
I have a poster in this, so I invite you to see the poster where we recall all our MPS 2 patients have been operated on hydrocephalus. And that's one thing that in our center we actively look at. The problem is not performing the MRI, but understanding the MRI, because MRI with brain atrophy is difficult to distinguish from the hydrocephalus. So it's sometimes not only the MRI, but also if you are really thinking that patient has hydrocephalus, you have to be more aggressive and perform other ways of measuring the pressure. The CN, the central nervous system pressure.
Doctors, we have a lot of questions. Just the last one, because I'm regarding that time asking for tips how they can improve the quality of life of their sleep of their kids, because they have patients with MPS 3, 2 that don't sleep at all or sleep very little. Just any recommendation or types, because our time is over. Sorry. No. Just so we can finish.
Just I would just say quickly to rule out all the problems that Mar commented on, and then begin to try. There's several protocols on this. To begin to try some pharmacological treatment if needed.
Yeah, the important is to the routines. Sometimes to starting with melatonin, and if it doesn't work, to start with other psychopharmacs and to rule out an EEG to see.
Thank you very much for your speech and your answered so many questions. Right now I'm gonna go to the next one with Dr. Maria Carmen Roqueta and Carmen Panis. And they're going to speak about anesthesia and the airway management in patients with MPS. Dr. Carmen Panis is a senior consultant in the anesthesia department in the Barcelona Children's Hospital. And Dr. Maria Carmen Roqueta is a specialist in reanimation, anesthesiologist, and pain therapy. And thank you very much, doctor. Sorry for the delay in the presentation. We appreciate you guys being here talking with us.
Mireia.
Dr. Carme.
Sí, jo vaig a preparar el menjar també. Sí, igual bé, Mireia, amb tu és fàcil, bonica. La gent ha preguntat molt, que això és l'important, no pegar la chapa del otro. Espera, a ver si estoy en silencio. Calla, calla.
Dr. Carmen, tú okay.
Yes. Now, okay. First of all, we want to thank you, the organization, for the kind invitation to participate in this international symposium. And we're going to talk a little bit about anesthesia, about the key points in anesthesia and airway management in MPS patients. We will try to help families to understand what's going on inside the operating room. Here is where we work, is a San Juan de Déu Children's Hospital. It's a child and maternity center in agreement with the public health system. We are a university hospital and the biggest children's hospital. We are a reference center for complex cases and rare diseases in Spain. Here is where we, the anesthesiologists, we spend most of our time during the day. This is one of our new central operating rooms, which are equipped with new technologies that help us a lot in the clinical management, surgical management, and anesthetic management of our patients. As you can see at the top of this image, we also like to say that we are a family-friendly hospital, and the hospital makes an effort to obtain a positive family experience when our patients are scheduled for surgery or when they have to spend a large period of time in our hospital for some treatments. But if we have to talk about MPS, we have to say that in 1980, MPS has been described as the worst airway problem in pediatric anesthesia. But nowadays, 40 years later, we can say that it's still a challenge for the anesthesiologists. It's a big challenge, not only due to the effect of the new therapies like the bone marrow therapy and enzyme replacement therapy, but also thanks to the new airway advanced devices that help us a lot in the airway management of our patients. As an introduction, we know that MPS is caused by mutation in 11 lysosomal hydrolase enzymes, which are required for the catabolism of the GECs. Then what we have is an impaired catabolism. That means that we have greater deposits in tissues throughout the body and cellular alterations that can be in different organs and different levels. In this slide, we have this nice smiling girl who shows us the clinical features that we have to consider when we have to anesthetize these patients. As we can see, we have an unstable neck. We have a patient with big tonsils, with abnormalities in the vertebral column, alterations in the temporomandibular joint. That means that probably they cannot open the mouth easily, which is important in anesthesia. And as the other colleagues said before, generally they also have epilepsy and mental retardation. So sometimes they cannot help us and understand what is going to happen inside the operating room. During the clinical course of this illness, these patients are scheduled for surgery at least a median of 4 times during the childhood. Some of these procedures are diagnosis procedures, and some other different surgeries and generally these procedures need general anesthesia. For safety reasons, we try to perform all these surgeries in the central operating room. Generally, in other type of patients, we perform some of these diagnostic procedures outside the operating room. But we know that in this type of patients, remote locations are associated with a high risk of complications. So we generally use our central operating rooms and morning timetable to do these surgeries. Generally, we begin our anesthesia day with a patient who comes inside the operating room walking with all the team together, and he can come inside together with one of the parents, the father of the mother, and once he's inside our operating room, we ask the patient if he wants to see a film or a cartoon. So he has only to breathe inside the facial mask, and once the patient is unconscious, then we place an IV line and we ask the parents to wait for us outside the operating room, just to try to get a good experience. This is another inhalational induction in the MRI, where you can see a patient who is breathing, who is helping us, breathing spontaneously, and we also offer the patients pleasant smells in the face mask like strawberry candy, so they are happy to play with us and to help us in getting sleep. She has the mother beside her, so it's a good experience for them. But one thing is our patients, they are MPS patients, and this MPS patient needs general anesthesia, so that's a challenge for the anesthesiologist, and we have to plan carefully what's going to happen inside the operating room, what type of surgery and what type of anesthesia we will provide to our patient. And we have to take care of the whole patient, but the most important thing in these patients, and we have to take care of this, is the airway. We know that all MPS patients, they have to be considered as a difficult airway patient because they have anatomical characteristics that makes them different from a regular patient. And when we talk about difficult airway, it means that we have the clinical situation in which a conventionally trained anesthesiologist experiences difficulty with the face mask ventilation of the upper airway, or with the tracheal intubation of the patient, or maybe in both cases. But the good point that we can say is that generally, when we have difficulty in MPS patients, generally we have difficulty with the intubation, but generally we can ventilate this patient. So that's a good point, because we do not get to the worst situation in which we cannot ventilate and we cannot intubate the patient. So what we have, as it is said before, is an enzyme deficiencies and GEX accumulation, which means that we have an airway obstruction in our patients. And this obstruction can be at various levels in the airway. These patients can have a narrow airway nasal, a large tongue, which occupies a big part of the mouth. So when we open the mouth, we just see the tongue. They also have the limited mobility of the ATM joint, so they cannot open the mouth as another patient. They have also the big tonsils inside the mouth, the short and immobile neck, so we cannot change the position of this patient inside the operating room when we want to intubate the patient. And they also have diffused thickening of the tracheobronchial tree and the supraglottis and glottis. So that together all these factors can lead to a difficult airway management. So what we do inside the operating room, so when it's possible, what we try to do is a minimal airway manipulation. So we try to keep it safe and simple as possible. We try to perform a local regional anesthesia, which is really very, very helpful in these patients. Giving always the patient a comfort sedation because they are children, so they have to be comfortable inside the operating room. They have to stay a little bit happy with us, or maybe watching films or with comfort sedation. And of course, we need to know the knowledge of the difficult airway algorithm, because we know that sometimes we begin with plan A, but we have to change to plan B, and we need to know what's going on in the next step, no? Because we are talking about difficult patients. Now we are going to show this patient. This is a arm surgery, orthopedic surgery of the arm of this patient. And as you can see, this patient has a peripheral block, and she's breathing spontaneously, and she only is receiving some oxygen by a cannula, by a nasal cannula. So that's perfect, because you can see it's a thickening of the airway, but we do not need to manipulate this airway. So that's the perfect point. But in some cases, this is not possible, and we need to go one step farther. Like the patient on the right, she's operated on, I don't know exactly what it was, but we need to manipulate the airway of this patient. And in this case, she's wearing a supraglottic device. This is a laryngeal mask, which is really very helpful in the management of these patients. So generally, we do not have big difficulties in inserting this laryngeal mask, and we can also intubate some patients through this laryngeal mask. There are a lot of predictors of difficult airway, but the most known one probably is the Malampati score. And we have to say that generally these patients are Malampati class 3 or class 4. That means that when they open the mouth, we can only see the tongue and sometimes a little bit of the soft palate, but we cannot see the rest of the structures. That means that the most known predictor of difficult intubation, because we cannot see what's inside the airway, so we cannot get easily to the vocal cords and the trachea. Of course, not all MPS patients, as this said before, and as everybody knows, are similar, so we need to know the differences and the clinical features of the different types of MPS. We know that Sanfilippo syndrome is the one which is the easiest one for anesthesia management. And of course, in all these patients, a preoperative anesthetic plan should be done. We begin the anesthesia of these patients in the outpatient clinic, when we see these patients and we talk with the patients and the family, and we decide which anesthetic plan should be done. We've said before that we have our advanced airway devices, which are really very, very helpful in our daily routine patients, and also with the difficult ones, like the fibrobronchoscopy, video laryngoscope, video bronchoscope, laryngeal mask, and others like the non-invasive ventilation, which is really very helpful at the end of the surgery when these patients go to the recovery room. Here we can see one of our operating room with all the difficult airway devices, video laryngoscope, video fibrobronchoscope, and also a tracheostomy table, which is sometimes necessary just in case, and an ENT surgeon beside us just in case we cannot intubate and ventilate our patients. Of course, when we have these difficult cases, we need helping hands around, and we need to verbalize what we are going to do inside the operating room. It is really important, because when we need help, we need helping hands. And we always say that one experienced anesthesiologist is not enough in difficult cases, and until intubation, 2 experienced anesthesiologists are needed in all cases, in MPS patients. And if we go back to the first or second slide, when we said that it was a big problem and the worst airway problem in pediatric anesthesia, nowadays we are happy to say that it's a challenge thanks to the advanced airway devices, but we cannot forget that respiratory complications are the most important cause of morbidity and mortality in pediatric patients, in the regular ones and in the complicated ones. So to avoid these complications, we have to plan carefully to get the best results in our pediatric patients. And just to conclude, we can say that due to the new therapies and new airway devices, we can treat these patients in a more safety way than we did before. We know that it's a teamwork. We need to work together to get the best of our knowledge in these patients. These patients require expert staff, 2 experienced anesthesiologists and an anesthesia nurse, trained anesthesia nurse. To minimize the risk of these patients, we have to do all the procedures in the central operating room and in the big hospitals, not in remote locations. Of course, the severity of the airway difficulty varies with the type of MPS. They are not all the same, and the airway obstruction is progressive, although the need therapies slow this progression. And a good point is that in our institution, we have a simulation programs with 3D models to train for the real cases, which is really very helpful. And this is our simulation head of an MPS patient made from radiological data from one of our patients. So we can train clinical situations and critical situations, and we can feel as anesthesiologists the difficulty in the airway management and to try to be ready for the real cases. And just to conclude, we have our ingredients, no? For our good results is a carefully executed surgery and anesthesia, thorough preoperative assessment, good communication, good team communication, optimal postoperative recovery, and of course an adequate infrastructure for difficult airway management and a good intensive care unity. So thank you very much for your time.
Thank you, Dr. Carmen. We have a question here about, she's a 47-year patient with MPS 4A. I have a narrow trachea with a kink below the larynx, so I cannot be intubated the normal way. ENT specialists who specialize in complex airway have said they can have fiber optic intubation up my nose, and I do not need a tracheo. MPS specialists say I do need to get a tracheo. Is there any MPS-related reason why there is a difference in opinion?
Of course, every patient is different, but generally we can try to do an nasotracheal intubation, a fiber optic nasotracheal intubation. It's always a good option in these patients. So probably it could be possible, but another thing that we don't know is the thickening of this trachea. So we have to individualize every patient to decide if it could be possible or not, but probably it could, because we know that they cannot open the mouth, but we can go through the nose and intubate the patients.
Okay. What are your suggestions regarding spinal cord compression during surgery?
Of course, depends on the surgery, but we also have potentials during surgery. So we try to work together with the neurophysiological team to get sure that they do not have deficits during surgery. In the big surgeries, when we have a back surgery, we have our neurophysiological doctors together with us in the OR.
Doctor, we have a lot of questions from people asking how can they contact you or put some other anesthesiologists in contact with you from other countries. They can send you an email or something so we can get in touch with you and they can share your experience with them.
Okay, yes. They can give them our email and they can email us. We will try to answer questions by email, okay. No problem.
Thank you very much, Doctor, for your presentation. And now we're gonna go to Dr. Andrea Borgo. He's an orthopedic surgeon and in the orthopedic clinic in Padua University Hospital in Italy. Thank you, doctor. Good morning or good afternoon.
Hello, everybody, and thank you, Amira, for your introduction. So I go quickly, and I have some disclosure, but not really relevant to that topic. So you are probably familiar with this biochemical classification of MPS, but I like to switch very quickly to an orthopedic point of view. We know that this kind of patient have a short stature, muscular weakness, joint stiffness, and in the upper limb, we have the carpal tunnel syndrome, the trigger finger, and the deformity of the hand. In the spine, the instability, the thoracolumbar kyphosis, the hip migration, the valgus deformity of the knee and the ankle, and the arthritis later on. I have to say that the mechanism from the lack of the enzyme activity and the final phenotype is not clearly understood. There are some major observations. I mean, the alteration of enchondral ossification, the inflammatory activation, the storage of the gags, but basically it's not completely understood. About the enchondral ossification, I'd like to show this electron microscopy. On the left side of the screen, you see a normal chondrocyte, in the right side a pathologic one of an MPS patient, and you see that the cytoplasm is full of vacuoles, and all the organelles are reduced in the strength and also in number, and they are displaced toward the plasma lemma. Later on, we see that there is some vacuoles are opening into the extracellular matrix, and at the end we find the rosette-like deposit. And this is the very beginning of the alteration on the enchondral ossification system. I don't know if you are familiar with the histology of the growing cartilage, but this is a normal one, all well organized, and this is a disorganized one in MPS patient. So this is the very beginning of the skeletal problem in MPS patient. And I like to show this sample from 8 weeks human fetus, when we see the transition from the mesenchymal tissue to the cartilaginous tissue, and we see that there is the appearance at this moment in time of the pre-ossification center. So the beginning of the disease is during the pregnancy, very early, around 8 weeks in the fetus life. So if we theoretically want to do something for the bony alteration, we should do something before birth. What are the therapies nowadays able to do for the bone? We know that the enzyme replacement therapy and the bone marrow transplantation and the gene therapy lead to a faster growth. They reduce the stiffness, reduce the weakness. But, you know, we have only an attenuation of the bony manifestation and not a resolution. And also from the study that nowadays are available in animals, experimental studies, I mean, we have almost the same result. So we're going to deal for a lot of years at least with the skeletal alternation. The first alteration is the short stature. Except for MPS 3, all these patients have a final short stature. It's a short and disproportional stature. I mean, the limbs are short, but the trunk is there is a prevalence in shortening of the trunks. So we have long limbs and short trunks. So the stiffness is another point. It's usually asymmetric with no sign of inflammation and painless. And in children, this is mostly due to the storage of the gags in the soft tissue. I mean, if we take an X-ray of the young child, the shape of the bone is almost normal. Later on in adults, there is also an alteration of the bony shape. In the spine, the mechanism is all the same. The alteration of the chondrocyte and the ligament connective tissue lead to some manifestation that can be instability, stenosis, and deformity. We can have only a mild situation, like in this Sanfilippo syndrome, and we see the irregular profile of the vertebral body and the slight platyspondylia. But after some years, like in this young girl aged 40, we have a late degenerative arthritis with radiculopathy and spinal stenosis. On the other side, we can have some more severe situation, like in this Marotolami syndrome with the early onset of the thoracolumbar kyphosis. And what are we going to do with the kyphosis? Are we going to brace these patients? Are we going to operate all of them? So this is something that is not clear in the literature, but we can take at least some inspiration from this consensus procedure. And we can see this indication for the correction of the thoracolumbar kyphosis are pain and sign of myelopathy, and the best age to operate to perform the surgery is between age 5 and 13, because when they are younger than 5, there is a high risk of failure of the implant, but they are too stiff to correct when they are older than 13. In the upper cervical spine, we can have some instability requiring stabilization, surgical stabilization, or stenosis. This is a normal subject, and this is an MPS 1 with upper stenosis, and this is an MPS 12 with a multi-level stenosis, and this is the possible surgical solution. So in the moving to the upper limb, we can see, we know that there is the possibility of the carpal tunnel syndrome, and I want to say that a carpal tunnel syndrome in a child is a very uncommon situation. In this famous review, out of 163 patients, 95, at least 50% as an MPS. So in presence of a carpal tunnel syndrome in a child, think about the possibility of an MPS. When you know that the patient is affected by MPS, you should follow the patient up, because more or less, with the only exception of MPS 4, half of the patients are going to develop a carpal tunnel syndrome. And when you operate the carpal tunnel syndrome, you cannot do a mini open procedure like a normal patient, but we have to open to remove all the gags in the peritoneum and the soft tissue, in the perineum and the soft tissue. Another point is the trigger finger. I wanted to stress that a trigger finger in a child, a trigger finger, I mean not the thumb, but one of the lesser finger, is a really uncommon situation. So in presence of a trigger finger that is not the thumb, think about a metabolic disorder in a child. And so this is another sign. And at the end, the hand of this patient is usually large, short, with the lateral deviation. And the fingers are stiff and flexed. What can we do with this kind of deformity? We can do some tendon release, especially in A1 and in A3. And this is the result at the end of the surgery, previous in the surgery and after the surgery. So the outcome is a good outcome if you do this kind of release. What happened to the hip in this patient? There is a lot of alteration in the hip, and I try to be more clear. we are going to lose during the time the sphericity of the femoral head. There is a very complicated method to quantify the sphericity of the femoral head, but the point is that we are going to lose the sphericity of the femoral head. There are some differences in the literature. MPS1 has a faster degeneration. MPS2 is not so fast, but the point is only one. We are going to lose the sphericity of the femoral head. Another point is that we have an augmentation of the cervical diaphyseal angle instead of a decreasing of the same parameter like in the normal children. And we have no decreasing of the acetabular index like is expected in normal child. And we have also, the acetabular index can increase or can increase or can be stable. And also there is a pelvic tilt who is another point very common in this patient. All these alterations lead finally to a migration of the hip. We know that the hip is going to be it can be migrate laterally, leading to a subluxation. Can we do something for the hip? Yes, we can do some surgical procedure in the proximal femur, like a variosteotomy, in order to have the femoral head inside the socket, or we can act in the pelvis part in order to have an augmentation of the coverage of the femoral head. The best procedure seems to be a combination between varus deformity and augmentation of the femoral head. Once that we restore the hip in this patient, we observe a progression of the compromission of the joint line and pain. So when they became adults, these patients are usually coming back asking for a total hip arthroplasty, like I did in this case. And it was a quite simple case, but sometimes the surgery is not so easy because there is no roof at all. And so this kind of surgery require a wide cementation or a bony implant. And sometimes they need a custom-made implant because they are too short for what we are used to use for common patients. In the lower limbs, it's common to observe a valgus deformity in the knee and in the ankle. And so during the growth, we can act with this little surgery. It's an hemiphysiodesis. We bridge the growing cartilage only in one side, let the growing cartilage to grow only in the other one, leading to a progressive correction, like I did, for example, in this patient with a good clinical and also cosmetic result. We can also correct the lower limbs with the traditional osteotomy. Just a case of a proximal tibial osteotomy, or another case of a distal femur osteotomy with a good result. And also in the lower limb, at the end, we have a degenerative arthritis. We can have a degenerative arthritis. So sometimes these patients are coming back required for a total hip, a total knee reconstruction, like in this patient age 33. So coming back to the previous slide, I hope that the orthopedic aspects are now more clear. And I have to stress that some orthopedic aspect can be sometimes the very, very, very first sign of an MPS, like the carpal tunnel syndrome, the trigger fingers, the stiffness, the kyphosis. So think about the possibility of metabolic disorder. The therapies nowadays available lead only to an attenuation, and the orthopedic manifestation are a cause of disability. And it's mandatory an orthopedic assessment. I mean, at least one per year in order to have the proper time, the proper correction at the proper time. So that's it.
Thank you, Dr. Andrea. We have a question about the carpal tunnel syndrome.
Yes.
If it can be cured by surgery.
Yes. Yes, I have to say the carpal tunnel syndrome require a very easy surgery for an orthopedic surgeon or for a neurosurgeon. It can be performed by both, and theoretically can be done with a local anesthesia. So the problem in a child is that is not able to relax and be calm during the surgery. So you need obviously a sedation. But it is not a general anesthesia, and so you can perform it with a local anesthesia. You have to do a very wide opening of the transverse ligament, otherwise they are going to have a relapse of the problems.
The decision to operate a patient with MPS, how many things you have to take in consideration to take a patient?
Sorry, how many?
What we have to take in consideration to take a patient to a surgery with MPS?
You really need a very rotated team because, as my colleague from the anesthetic department said before, they are complicated patients, and the problem is all the time around the corner because the airways management is not so easy, and so you have to when you see that there is a surgical indication, the surgical indication is needed, you have to talk very closely with your colleagues from an anesthetic department, and to be ready to find the proper colleague to do the anesthesiologist, to have an ERT colleague for intubation with the fibroscope ready, and so it's not so easy, but in the proper way we can do it.
The last question is optimum age for egg plates in ankles. How long would that be possible?
In ankle, okay. So starting from the observation that they are growing very, very slowly, we should perform MEP physiodesis very early, especially in MPS 4 and MPS 6, because they are growing just a little. So MEP physiodesis should be done around age 4 or 5, both in ankle and in knees. The tibia is growing mostly in the proximal part, I mean close to the knee, and so the correction is a little faster around the knee, while around the ankle the growing speed is less, and so you have to wait for a long time. Usually I perform the MEP physiodesis in the ankle, and I let the plate inside forever, because we need years and years for the correction. While in usually sometimes I have at the end of the correction in the knee, I have to remove it. It never happened to me in the ankle.
Okay, I would like to thank you all, and